Right. We started with healthcare policy, and the first thing I did was to try to explain the learning outcomes that we want to achieve for LO1. We need to achieve the assessment criteria 1.1, that we should be able to analyze the approaches to healthcare policy. And 1.2, we need to critically assess the influence of funding on policy. And then we need to critically evaluate healthcare policy in one national context, which we will use UK as the national context. Is that right for everybody?
Yes, that's fine.
That's okay.
Okay. Right. So I'll first want you to understand the concept of healthcare policy. Once we are able to understand that, then we should be able to, when we are asked to analyze, then you will be able to analyze. Right, so healthcare policy refers to just decisions or plans or actions that are undertaken to achieve specific care goals within the society. And that is a WHO definition for healthcare policy in 2019. In fact, a policy, if you take it in the ordinary context, if you have a policy at home, then it's just decisions that yourself, maybe your spouse, have taken, plans that you want to achieve something at home. That could be your plan. So if we talk about healthcare policy, it's also decisions, plans, or actions that a nation wish to undertake in order to achieve specific healthcare goals within that very nation or society. Right. An explicit healthcare policy can achieve several things. Right. It defines a vision for the future, which in turn helps to establish targets and point of reference for short and medium term. So that means that we could have a short-term policy, a medium-term policy, and long-term policy. Right. But whether short-term, medium-term, or long-term, it's just decisions and plans and actions that are taken to achieve a specific goal. Again, healthcare policy outlines priorities and the expected roles of different groups, and it builds consensus and informs people on whatever decision they decide to do. Right. When we say healthcare policy, it's quite broad. It can encompass financing and delivery of healthcare. It can cover access to care. It can deal with quality of care or health equity. All these are part of a healthcare policy. In the current regulatory environment in the world, health policy is growing to cover everything from the design phase to implementation phase of health insurance plans. It also covers the efficiency and operation of major hospitals. So if we think that our hospitals in the UK are not efficient and they are not operational, we make policies towards making them efficient and operational. That is a healthcare policy, right? And the regulations that keep patients, hospital, and prescription drugs safe are all part of our healthcare policy. So you could see that healthcare policy is quite broad, right? It also encompasses any laws, regulations that will lead to better implementation of insurance policies, hospital care policies, healthcare research that might affect doctors and patients. So along the line, you will see the Health and Social Care Act coming in. It's part of policy, because any policy that does not come with regulation will not work, because the regulations are supposed to help to make sure that the policies are implemented. So you could see that the healthcare policy covers all healthcare acts that are implemented within a specific context. Therefore, the area of policy focuses on the design and the cost structure. So even costing of healthcare is part of policy, right? And as well as regulations govern the operations of the hospitals and clinics. So there are policies on regulations, of which, in that case, the Care Policy Commission comes in. How they regulate. They are all part of what? Healthcare policy. Right. And then when we talk about approaches, there are different approaches across the globe. And Tax 1.1 asks us to analyze the approaches. Now, we have the National Health Service approach to policy. We have the private healthcare service. We have local and national organizations coming in. But whatever approach a country decides to use, it should always fall within the WHO global agenda on healthcare. Because what the WHO brings out are target decisions that need to be achieved globally. So based upon the global policy and the global agenda, every country within its confines try to pick areas of the global agenda that will suit the needs of the specific country. So if we feel that in the UK, our focus is on free healthcare for all, because we feel that it's an essential need, then of course we'll go for the National Health Service System or approach. Now in the US, they felt that it should be private. That is their priority. They think that if you go private, it's more efficient. If you have money, you can have it. There are some countries that mix both private and then national, right? Of course, in the UK, even though it's National Health Service, if you don't want to wait and you wish to have your issues addressed, you can go on the private. But the main system, the main approach that we use in the UK here is the national approach, right? So no matter what approach you use, it will definitely have to fall within the global agenda of healthcare. And then there are some local and national organizations that also take active part in the provision of healthcare. And a typical example in the UK is the Cancer Research UK, right? So that look at the approaches. So what you need to do to be able to answer that tax 1.1, when we go back to the screen, 1.1, is to look at the different approaches. It's an analyze the approaches. Analyze, look at the National Health Service, look at the private health service that works in the US, look at a country that combines both. And then ask yourself, is it working? Is it efficient? Is it able to address the needs of people in the country? So if you look at the National Health Service in the UK and you want to analyze it, ask yourself a few questions. Is the NHS policy of trying to provide healthcare for all at the point of delivery, is it efficient? Is it able to address the need of all people in the UK? What about people who need some specialized services and they can't get, and they have to go outside UK to Europe to go and have the services they need? So is it actually working in the UK? Is everybody satisfied? Right, so you look at the downside and then the upside. The upside, fine, everybody is able to access health services. However, there are so many instances where parents would like to take their kids out because they feel the services are not being offered by the NHS and they want to go out. There are so many litigations where parents feel that they have to take their child to Italy. The recent one that happened where parents were forcing the government that they want their child to receive treatment outside, and the relatives and the NHS doesn't allow it. So there are so many conflicts here and there. So ask yourself, is the national approach that we are using in the UK effective? If it's effective, why? If it is not effective, why? So this is just analyzing the approach. And remember, the key command verb is analyze, not describe. So when you analyze and you try to look at what works well in the national approach, what doesn't work well with the national approach, in your opinion, backed by facts that you can get from literature. And then if you look at a private approach, Is it efficient, as the US people are saying that, oh, this private is efficient because they have to make sure they provide the best services that will meet customer demand? Is it actually efficient, as they say, in private hands? Is it not expensive? Is everybody able to access it? You can look at issues like the Obamacare, where Obama felt that the private health service approach is leaving so many people behind. And therefore, Obamacare was coming in to make sure that health service delivery will be available for all. So these are all the issues that you can discuss within 1.1, analyzing the approach. So the main approach is that the National Health Service approach, the private approach, the mixed method, and the provision by local and national organizations, which all should fall within the global agenda of healthcare. All right. So if we look at the 1.2, it says that critically assess the influence of funding on policy formation in the national context. Critically assess. Right. So within the national context, I still want us to look at the NHS, because that is what we are most familiar with. Right. So a brief history of how the NHS came, where as far back as 1948, coming from the Beveridge Report in 1942, where they felt that in the UK, NHS must operate under the principles of universality, free at the point of delivery and equity, and is paid for through taxes and national insurance. And as I was saying last time, even though there are other sources, they are minor. We've got health surcharge for people who are not resident in the UK. Apart from that, we have car park charges. Those are all monies that come in. But the main funding that comes through is through taxes, mainly, and then national insurance contribution. So that is the nature of the funding. And the next slide, you're going to look at how the money comes in and then how it is dispersed across board. And then we will look at the funding policy, how it will influence our policy and whether the policy is working or not. So that is the key issue that I want you to understand. We are using the NHS UK because there are other funding methods which will be private funding from all sources, but we want to limit ourselves to the public funding because we emphasize on the UK. All right. So in terms of funding, there are so many problems. And one that I want you to keep at the back of your mind is the austerity and the funding cut. Keep it at the back of your mind. When you finish 1.2 and I'm going through how you can critically assess it, then you begin to appreciate what the funding cut and austerity measures does to frontline services. Right. So let's look at the funding, finance in the NHF. Where does it come from? We should be able to understand that. So the money straight away comes from the treasury. So if you look at the red diagram, the pink or red diagram down there, it explains all the theory around it. Right, so we have the HCM treasury, where the money comes in, all the taxes are there, so it comes into the Department of Health, and about 107 billion comes in there, and then 96 goes to the NHS England, and then 64 billion goes into commissioning groups. So under that, you could see that public health is directly under the Department of Health. Right, so some of the money goes into centrally managed projects and services, arm-left organizations such as NICE and the rest, National Institute of Clinical Excellence, and then public health spending all goes into that. And then we have the NHS England, nationally commissioned services are there, and then we have clinical commissioning groups, which are local commission services within the GP sector. So that actually shows how the funding comes in. And then you really ask yourself, how does funding influence policy formation in the national context? Let's look at the next slide. This is 1.3. So let's go back and look at that. So if you are asked to critically assess the influence of funding on policy formation in the national context, which is the UK, what are the issues that you have to look at? I first mentioned the funding cuts and austerity measures. The money mainly comes in from taxation. It goes through the HCM Treasury, which pushes the money down to the Department of Health, and all agencies receive their money. Right. What would be the effect of funding cuts and austerity measures? The consecutive government of David Cameron at the time tried to balance the books of the government. And that means that so many areas were cut, not healthcare only, but health received a major cut. And that means that policies that were meant to be carried out are not able to be carried out. This is an unintentional consequences of trying to balance our books. So the austerity measures were put in place. So the money that comes from Treasury through the Department of Health to NHS England, Public Health, and the GP aspect of the commissioning groups were all cut. So what did we see? We saw a long waiting period as an emergency. Instead of you begin to ask yourself, is it actually an emergency? It's no longer an emergency if you are able to wait for about 4 hours at A&E. What about other services within the NHS? Maternity services were cut. And then so many services that the government deemed as not essential were cut. In terms of fertility, if you are above a certain age, you are not going to get that treatment. It was cut. So many areas suffered with it affecting the number of nurses that we have, number of consultants that we have. So because of the funding cut, the policies of improving the health outcome of patients in the UK actually suffered. So you can argue your case out starting from how important funding is for any policy. In fact, without money, no policy will succeed. No matter how good or how well designed the policy is, without money, it's not possible to carry them out. And then you come down to look at the main source of funding, which is through taxation and national insurance for the NHS, how it goes through, comes to the HCM Treasury, how it goes to the Department of Health, NHS England, and the commissioning groups. And then raise the issue of funding cut, which actually shortened the flow of cash into all sectors, and how unintentionally policies that are meant to provide good patient outcome has actually suffered in the country. This answers tax 1.2 in a very simple way. Do you understand that?
Yes, thank you.
Good. Yes. Good. Let's look at the 1.3. 1.3 saying that we should critically evaluate healthcare policy, again, in one national context. So if you feel that you are good in looking at healthcare policy in Nigeria, fine. If you want to do it in Ghana or Pakistan, fine. But let's look at specific context in England. Right. So behind the policy, as I said, is what? An act. Act is simply legislation or law. Now, these laws are meant to make sure that the policies work. Let me give you an example how policies and then acts or laws or legislation work. For example, when they came out with the health and safety policy for the country, they have to bring in the Health and Safety Act 1974, right, which was designed by the health and safety executives. So that is the legal framework in which health and safety policy is implemented. So for instance, if an employer refused to provide a hard hat for construction workers, gloves for nurses, apron for them to wear, creams to be able to do wash their hands and the rest. If they refuse to provide, then it means they didn't adhere to the policy. So what will happen? The Health and Safety Act, which is the law or legislation, will not come into play. So when the person is taken to the disciplinary action, they are not going to use any other law apart from the Health and Safety Act 1874. In the same way, we are trying to evaluate the health policy in the national context, which is in the UK. And as to how it works better or not, we also have to factor in the Act, Health and Safety, Health and Social Care Act, which is the legal basis upon which all policies are implemented. Okay, having done that, we look at the overview of the Health and Social Care Act, which is the regulation or law, and how the new NHS values try to improve healthcare policy in the country. Number one, there was a move to clinically led commissioning, because they don't want people who are not clinicians to be managing the affairs of the hospitals. So they moved to clinically led commissioning, where they have to abolish the 152 PCTs in England. It's simply primary care trusts. And they replace it with what? The clinical commissioning groups, CCGs, all to make sure that policies will be efficient. Right. And then they also brought in the idea of increased patient involvement, that for policies to be effective, there should be input from what? Patient. So patient involvement, even though it was there before, from 2012, it was enforced. And then there's also a renewed focus of importance of public health. Public health also became a very important aspect of it, because there are so many issues like obesity, people not being able to exercise well, smoking problems. So much emphasis was therefore placed on public health as part of the policy. So public health now took a central role in the policy framework within the UK. And then they also streamlined arm-length bodies, such as the National Institute for Clinical Excellence. What do? Their role is to make sure they provide clinical guidelines to support healthcare policies in the country. So they produce all the guidelines.
Could always use onions in butter to go with them.
What? Go on.
Sorry.
Okay. So arm-length bodies such as the NICE, which is the National Institute for Health and Care Excellence, were also empowered so that they will be able to provide enough guidelines, certificate, evidence-based guidelines that will be able to help policies in the UK run smoothly. Again, they allow healthcare market competition in the best interest of patients. So when they are going to purchase anything, they have to make sure that it is floated on the market so that they'll get the best quote and the best implements or whatever they need. This is not left over to the managers. They float it out. And if you can remember what we did in the funding, the other model in the other model on managing the healthcare, where we have to do a bit of accounting. The last learning outcome that we look at was how we are able to do costing and make sure we select right people for the bidding. That was the last bit. In fact, they have encouraged that so that all healthcare purchases are competitively bidded for. And they are meant to make sure they will always have the best. so that their health policies can be implemented in the right way. All right. So I'm going to let you look at an entire framework, how policies are implemented, the entire framework. So we have the NHS England, which is the commissioning group on the left. We have the monitoring and regulation and training and development. These are the core ones. So under the commissioning group, we have the primary care, where we've got the GPs at the bottom, and then we have Public Health England, which sit down to issues about immunization, screening, and the rest. And then within the two, we have commissioning support units, which help and make sure that the money goes to the right place. We have the critical commissioning groups, which are groups that again look at areas that money must go to. And then we have the health watch. Health watch is simply what do I say? The patient mouthpiece. If anything within the health sector is not going on well, Health watch is there to make sure they bring it out. So what they do is to collect information from patients and all service users, because individual patients cannot fight for their demand, and when things are not going right, they cannot fight for it. So Health watch is there to make sure that people's voices are heard. Right. So under that, we've got the secondary care, community services, mental health services, rehabilitation services, and local public health services. If you look at the bottom, apart from the primary care, we have specialized services, offender healthcare, which happens in the prisons. We have the armed forces healthcare, which is also crucial to the UK. And then we have the immunization aspect. So all this is more or less the commissioning aspect of it. Then another important aspect that ensures smooth running of our policies in the UK is the monitoring and regulations. And what I'll emphasize on here is the fourth square, the Care Quality Commission, CQC. They actually make sure that they monitor whatever is going on in the healthcare sector and make sure all policies are implemented according to the standard that has been set. And then below that, we have data services, data and evidence, where the National Institute of Health and Clinical Excellence make sure that they have the right evidence base to be able to support health care. And then we have the Health and Social Care Information Center. And the right-hand side, the last bit of this is training and development, where they provide health education for England. And they make sure that any training needs of clinicians, anybody within the health and social care sector is able to receive the training that they need. They also provide educational materials. If you go to hospitals and the rest, we have a lot of leaflets around. All these things are put in place in a mechanism to make sure that policies in the UK are implemented in a very in a way that will suit the needs of service users. And then we will not focus much on that. On the right-hand side of it, we have the Secretary of State for Health on top, who is responsible for the Department of Health. We have the Chief Medical Officer, who is the UK's government principal medical and scientific advisor, and at the same time a professional lead for doctors in England, and then a professional lead of all directors of public health in local government. And then we have the medical director role, we have the chief nursing officer, and the chief professional officer. So they have robust system in place to make sure that every aspect of the healthcare policy in England is implemented very well. Right. Let's look at some of the things that are outside the UK in brief, then we move on. Outside the UK, we have outside England, we have NHS Scotland, NHS Wales, and NHS Northern Ireland. We will not go into details because they've got the same structures in place. The difference is that they've got difference in names. So if you look at Northern Ireland, instead of having the CCJs, the critical commissioning groups, they have the Health and Social Care Board, which is the same thing, right? They hold overall responsibility for commissioning services through the 5 local commissioning groups. So they have 5 local commissioning groups, and then the Health and Social Care Board are responsible for all of them. And then we have 5 Health and Social Care Trusts. And instead of the NHS Foundation Trust, they have the Health and Social Care Trust. So different names. And then instead of the Health Watch that we have in England, we have the Patient and Client Council, right, which is a powerful independent voice for patients. So you can see that the main structures that hold the policy in England are the same for the devolved countries, but then they have been given different names. And then in Northern Ireland, we have the Regulation and Quality Improvement Authority. This is equivalent to the Care Quality Commission in England, right? And then we have Public Health England. They have what is called Public Health Agency. It's the same thing. But the structures, as I showed you in the previous slide, is the same as in England, but they've got different names. In fact, if you go to Wales, instead of the CCJs, they have the local health boards, right? So it's the same thing. And there are 3 national trusts. They have the Welsh Ambulance Service, the Parliamentary NHS Trust, and the new public health body for Wales. So it's the same. And then they have 7 health councils. They represent the health and well-being interests of the public in the district, right? If you look at Scotland, which is more devolved, they also have 14 NHS boards, which is equivalent to the clinical commissioning groups, CCJs in England, right? And then they have 7 special boards and health improvement boards that provide national services and scrutiny, as well as public assurance of healthcare. So you can see that here they have combined the services of CQC, everything within that context. So if you see that, if you go back to the previous slide, all these structures are there to make sure that policies are implemented in a very efficient manner, right? So I'll give you that of England and a bit of other countries within the United Kingdom. The only thing is that they have got different names, but they perform the same role with the same structures in place. Now let's look at specific policies, because we've been asked to do what? Critically evaluate a health policy. So let's look at policy priorities within the UK. Right. The DAXI review 6 key clinical goals in relation to improving preventing care in the UK include tackling obesity, reducing alcohol harm, treating drug addiction, reducing smoking rates, improving sexual health, and improving mental health. And with mental health, they even brought in the latest act. If you Google, you can find it, the Mental Health Act 2018. It means that the government is still quite serious about improving the health of people in the country. This runs through public health, and they are being implemented in the GP surgery. So these are key priority areas that we'll be able to look at, and we'll try and evaluate whether these policies are actually working or not. Because the tax is telling us that critically evaluate healthcare policy in one national context. So we will look at this standard and see whether within the framework of the commissioning groups, public health, training and development, and monitoring, we are able to do justice to all that we have here, right? Tackling obesity, reducing alcohol harm, treating drug addiction, reducing smoking rates, improving sexual health, and improving mental health. Are they actually working? These are policy priorities. Now, let's look at the next slide. There are preventive programs to address the issue that I showed you at the previous slide, those 6 key priority policy areas, right? Programs have been put in place to address those issues that I showed in the previous slide. To address all those issues, we have got preventive programs put in place. Number 1, there's a program of assessment of cardiovascular risk and identification of people at higher risk of heart disease. And this is generally performed within the GP surgeries. We have specific preventive programs like suicide, stroke accident in local schools and communities. We also have family planning services and prevention of sexually transmitted diseases programs, often with emphasis on young people. We've also got a variety of prevention and health promotion programs that relate to lifestyle choices that are also, even though there are public health issues, are delivered through GPs and community services, including alcohol and smoking cessation programs, promotion of healthy eating. We've now got even school children being allowed to take better dinner to school, and if they are getting school feeding, they are part of a school feeding program. They have to make sure that the school provides healthy eating for them, healthy food for them, and physical activity, exercise. Right? So these are all programs that were put in place to address the issues that have been described here. So, if you are asked to critically evaluate healthcare policy in one national context, in which this case we will use UK, we look at those policies, look at the preventive programs, and then evaluate it. Are they actually working? If we want to reduce obesity in the country, have we been able to do it? Are we succeeding? What are the problems that sometimes prevent us from achieving these issues? That means that you are critically evaluating. You are not describing or explaining, but you are critically doing what? Evaluating. Critical evaluation. So let's look at some of the challenges. Right. We want to do all those things, but we still face problem. Why? Because even though we have to tackle the burden of chronic disease, cardiovascular, and the rest, we can see that life expectancy in the UK has increased. And that comes with the burden of chronic disease, such as cancer and neurological disorders, which you can't do anything about it. There are also negative environment and lifestyle influences, which actually create pandemic of obesity and associated conditions such as diabetes and cardiovascular diseases. There are some lifestyle choices that people make, which are not actually helping us to achieve our policy of trying to reduce obesity, smoking, and all that. It's difficult. Why? Because there are some lifestyle that people are not willing to give way or to stop. No matter how promotions that are being made through Public Health England and support from the GP and the community services trying to help people get out of some lifestyle choices. I mean, currently there are days that drug addicts have to go to a GP surgery to go and see their GPs to make sure they support them and make sure they wean them out of their drugs. And these are all issues that are going on. But are we actually succeeding? What about pressure on healthcare infrastructure due to increase in net migration? This is a very serious issue. And probably that might be a catalyst to people trying to vote to leave the UK. Because net migration, it's not in favor of UK. If you look at people who go out of the UK, people who come in, those who come in are in excess of those who go out. So what happens? We have not increased our healthcare infrastructure since Labour government. We have not increased them. However, there are more people coming in. So what happens? There are pressure on healthcare infrastructure, right from nurses, doctors, admin staff, machines that are being used, the physical infrastructure, the hospital per se, have not been increased since Labour time, even though there have been few expansions here and there. So these are all challenges that actually makes it difficult for the health policy that we've set in this country with nice structures in place. The commissioning group coming in there, public health coming in there, monitoring, evaluation, everything coming to make sure that those target areas will be able to succeed. But then, because of increase of net migration, there's so much pressure on the system that the system is not able to cope, and therefore we are failing in a lot of key indicators of healthcare. Most people go into the hospital with headache, the headache goes, and then you come home with infection. These are all issues due to pressure on the existing system. And then to make matters worse, we come back to the austerity measures and the funding cuts. There are so many frontline services which have been cut. In that case, how are we going to achieve the policy targets that we have set as a country? So you could see that when you are asked to critically evaluate healthcare policy in one national context, look at all the structures in place, look at key policy issues that we need to achieve, and then look at preventive measures that have been put in place and ask yourself, are they working or not? If they are not working, then look at such challenges that I've just put up on this screen and discuss it around this. Because life expectancy, of course, has increased. And that comes with what? A burden of chronic diseases. We can't do anything about it. Right? And then there are negative lifestyle influences. There are gyms springing out all over. Some people will be able to exercise, get more active, and then that will be able to help us beat problem of obesity, try to target children in schools so that they eat good food, making sure people will become active in the country. But is it working? Has it been able to reduce cardiovascular diseases? Has it been able to reduce diabetes? What about pressure on healthcare infrastructure due to net migration? What about funding cuts? Without funding cuts, will we have been able to balance the government books? No. But then the funding cut has got its own what? Unintended consequences, because most frontline services has either been cut or removed. Sometimes a maternity service or children's service within the hospital is moved to another hospital just to make sure they'll be able to save. So these are all issues, challenges that you have to evaluate to see whether those key policy things that we target ourselves to achieve and all the preventive measures that we put in place are actually working. So when you're analyzing them within the framework of the challenges that we face in the UK as far as the health care system is concerned. Can you ask me some question, please?
I don't have any questions. I'm quite happy with that.
Good.
I'm quite happy with what the challenges are. I work with them every day.
Okay, yeah, good. So when you are asked to critically evaluate, look at the part of the policies which are working and look at the other parts that are actually not working. That makes critical evaluation and then draw your own conclusion. What needs to be done? That is what is expected for level 6 or level 7 essay. Right, so again, we're going to use just the UK within the national context because we are more familiar with the UK. Joseph, are you there?
I am, yes.
Good. Are you following what is going on now?
I am.
Good. I'm happy to hear that. Good. Now, that is that about learning outcome 1. Right, so what I'm going to do, I know Christina's time is drawing near, but I'll try and then go through the learning outcome 2 briefly. If we are not able to finish, I can complete the recording and then upload it so that you can play and then understand it. Is that all right?
Yeah, that'd be brilliant. Thank you.
Okay.
Oh.
Right. So, learning outcome 2, we need to understand the social and cultural context of healthcare. Social and cultural context of healthcare. And then 2.1 will ask us to assess the impact of culture on healthcare. Right. So, to begin with, at least we need to talk about what is culture and how important it is in determining what actually happened in the healthcare system. So culture is just one of the important determinant factors in healthcare preference and practices, because the culture of people will determine what they will look for. Right. And then the extent to which patients perceive patient education as having cultural relevance for them can have a profound effect on their reception of information provided and their willingness to use it. We have got different cultures, right? So if you are, for instance, doing a campaign on prevention of HIV or any sexually transmitted diseases, you will need to understand the culture of the people. If it's an Islamic community with their own culture, the way you have to sell the campaign to them should be different, because there are sensitive issues within their culture that people are not even willing to even mention. In Western industrialized societies such as the UK, which see disease as a result of natural scientific phenomena, they advocate medical treatment to combat microorganisms or use sophisticated technology to diagnose and treat diseases. That is the UK. Because they believe that in order to combat any disease, we need to combat the microorganisms. Whereas in some cultures, they will look at the disease from a cultural and probably spiritual perspective. Or maybe this is a curse. Something has happened, and that is why this is happening. So the culture is so much important. It actually greatly impacts on healthcare. So culture is so much sensitive, and it plays a major role in patient compliance. As to whether patients will actually comply with the rules and support and guidelines given to them by their GPs or their consultant will depend upon their culture. Someone will tell you, as for this disease, is caused by a witch. Or maybe I have committed a crime, so this is the result of punishment. In fact, when HIV/AIDS was first diagnosed, even in America, which is supposed to be an advanced country, because they have not been able to isolate the virus at that time, they were blaming it on promiscuity, targeting the gay and lesbian community in the US. So that is the cultural area. They didn't believe it was caused by a virus. So even in advanced countries, sometimes culture will usually impact on healthcare. That's a typical example when HIV was first detected in the US with patient 0 in the US. So that is the cultural aspect of it. Unfortunately, there are some communities even within Africa and parts of Asia who still believe that the HIV/AIDS is not caused by what? A virus. So no matter how campaign you will make about protection of yourself using condoms and the rest, people still believe that this is a case or this is as a result of a witch in my family trying to inflict harm on me. So these are all issues that we need to assess how culture impacts on health care. So you look at the westernized societies and you look at developing countries, and you can combine the two with an experience to be able to assess the impact on culture. Right. Other societies believe that illness is the result of supernatural phenomena, which I've already explained. And then what that means is that they will promote prayer or other spiritual interventions that counter the presumed disfavor of powerful sources. And one study showed that a group of Cambodian adults with minimal formal education made considerable effort to comply with therapy, but did so in a manner consistent with their underlying understanding of how medicine and the body work. This is a typical example of Cambodia. They have their own understanding how medicine and the body works. So it's not what you are saying, but what they think within their culture. Again, we have the extended family, which has significant influence. And the oldest male in the family is often the decision maker and the spokesman. So when anything happens, whether it's a disease or whatever, an individual disease is not an individual disease in developing countries, in some cultures. When somebody is sick, the whole family is sick, and if it means money, they have to pool resources together to make sure the person is taken care of. That is culture and how it impacts on healthcare. Of course, if you look at the UK, it's different because you don't have to rely on the oldest person in the family because you don't need that person's support in terms of finance because the health system is there, NHS is there for you, so you can quickly go in for any treatment that you want. So that is how culture impacts. And then the interest and honor of the family are more important than those of individual family members. So if the whole family say, no, don't tell anybody you've got STD like gonorrhea or anything, you don't have to say it. Because the honor of the family is more important. There are so many issues in terms of culture, of people living in the UK from other communities or other countries who are resident in the UK that actually conflict in the system that we have in the UK. It's sometimes shocking to believe that people, families from Pakistan, for instance, can decide that if you don't marry this person, then you have dishonored the family, and therefore they have to get you out of the family home. And in some extreme situations, people are killed. These are all based upon what? Culture. So among Asian cultures, maintaining harmony is an important value. Therefore, there's a strong emphasis on avoiding conflict and direct confrontation. Due respect for authority, disagreement with the recommendation of healthcare professionals is always avoided. So they have due respect with authority. So you have to understand authority before you'll be able to make sure that the right procedure is taken to avoid any conflict within professionals within the health social care sector. Right. Among Chinese patients, because the behavior of individual reflects on the family, mental illness or any behavior that indicates lack of self-control will produce shame and guilt. So even among Chinese communities, even within the UK, that mentality is still there because it's culture. As a result, Chinese patients may be reluctant to discuss symptoms of mental illness or depression, which is true, especially if they are not educated and they are just living in the UK. Again, some subpopulations of cultures, such as those from India, Pakistan, are reluctant to accept a diagnosis of severe emotional illness or mental retardation because it severely reduces the chances of other members of the family getting married. There's much evidence on this because they do inter-family marriages, cousin marriages, and the rest. Certain diseases are occurring within the lineage. When brothers are marrying sisters and they are marrying cousins and aunties and the rest, so you could see that it is there. So such families, basically from India and Pakistan, are reluctant to accept those diagnoses because it will put some sort of stigma to the family. So even though the person is sick and needs treatment, because of what others will say, they will not accept diagnosis. And all this will impact. Because if you accept that where there are mental issues running through cousins and aunties, who is going to marry in that family? So these are all cultural issues that need to be discussed in detail. A lot of them, in Vietnamese culture, mystical belief explain physical and mental illness. So mental illness, even physical illness, are all mystical in nature, where health is viewed as a result of harmonious balance between the poles of hot and cold that govern body functions. Look at how they understand it. but that is their culture. So Vietnamese don't readily accept Western mental health counseling and intervention, particularly when self-disclosure is expected. However, it is possible to accept assistance if trust has been gained. So if you really want a Vietnamese, then you need to have time to explain, support them before you'll be able to gain their trust. And these are all issues of culture. So when you are asked to assess the impact of culture on healthcare, you should be able to bring all these examples. So this slide is very detailed. That will give you all the examples that you need for your assignment. The Russian experience with medical practitioners has been an authoritarian relationship in which free exchange of information and open discussion was not usual. So even within Russia, certain things are not openly discussed. As a result, many Russian patients find it difficult to question a physician and to talk openly about medical concerns. Patients expect a paternalistic approach. The competent healthcare professional does not ask patients what they want to do, but tells them what to do. In fact, this is not Russia alone. In many developing countries, the doctor is seen as a mini-god. Therefore, whatever he says is final. For instance, if you go to a GP and you tell them that I'm feeling very feverish, I've got headache, and I'm a bit hot, so I think this might be malaria, the doctor will tell you, if you know it's malaria, then go home. They won't even allow you to talk. This is all based on culture. Whereas in the UK, people are able to have frank discussions with their GPs and then tell them alternatives and what needs to be done. This is all culture. So that is the culture. Now let's look at the second one, which is 2.2. What is the impact of society on healthcare? So 2.1 is all about culture on healthcare. Can you ask me any question about the culture before we go on to the society?
It's well understood.
Well understood.
Yes, but for it's the referencing part on the culture side of things.
Okay, at the end of the slide, there are so many references there that you can use.
Okay, all right.
Yeah, so at least you can have something to use. Okay, right. Christina, are you there? Hello, Christina? Oh, probably she's gone. Oh, she's still there. She's still there. We are three online. Okay, Christina, we are moving on to the impact of society on culture. Right, society. Many African Americans participate in the culture that centers on the importance of family and the church. And there are extended kinship bonds with grandparents, aunts, uncles, cousins, or individuals who are not biologically related, but who play an important role in the family system. In fact, if you go to the US, the African Americans have got that closely knit family where everything is a whole about the society, not about individual. Whereas in the strictly white communities, it's you and your wife. So whatever decision you take is based upon what you say, not what society that you live in would say. In fact, the African American society is the right model that was imported from Africa. Because Joseph, if something is wrong with you, it's the whole society, right? They will come and think about you. Usually a key family member is consulted for important health-related issues. And sometimes the church is an important support system for many African Americans. So the society as a whole will come together and support in terms of any decisions concerning health. And as can be seen, each ethnic group brings its own perspective and values to the healthcare system. And many healthcare beliefs and healthcare practices differ from those of the traditional healthcare culture. Unfortunately, the expectation of many healthcare professionals has been that patients will conform to mainstream values, which is not the case. So the society plays a very important role, and culture also influences that particular society. So healthcare professionals shouldn't expect people to conform to mainstream values. And such expectations have frequently created barriers to care, now have been compounded by difference in language and education between patients and providers from different backgrounds. Again, cultural any question?
Oh, no.
Okay. Again, cultural differences affect.
I'm sorry, but I'm going to have to go. Okay.
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 Bye.
Okay,
Bye.
right. Bye.
Bye.
Bye. Again, cultural differences affect patient attitude about medical care and the ability to understand, manage, and cope with the cause of the illness. Right? Right. So patients and their families bring culture, specific ideas and values related to concepts. Joseph, are you there?
I am there, yes.
Oh, okay. Something just happened. I think Christina is going out and something just happened. Let me just get back on the system.
Okay.
All right. Good. Are you following?
Yes, I am, yes.
Okay. Let me get it back on. Okay, I'm sharing the screen again. Right, so you could see that, just a minute.
Mm-hmm.
You could see that society as a whole plays quite a major role. Right, let's look at the next slide, which is cross-cultural variations. Cross-cultural variation within cultures.
Mm-hmm.
Within cultures also exist. And then there are need to be plans and strategies that can be used in working with patients from different cultures as displayed in this table. Right. That is just to provide how society as a whole and the culture will be used. Because if you look at the UK, for instance, we have people from different cultures. Right. We have the Nigerian community here, we have the Ghanaian community, Pakistani community, Indian community. So there are cross-cultural issues there, so that we need to be able to learn from each of them if we are able to make sure that we will provide the best service for patients. So number one, learn about the cultural traditions of the patient you care for. If you are a GP, you want to succeed. Pay close attention to body language, lack of response, or expression of anxiety that may signal that the patient or family is in conflict, but perhaps hesitant to tell you. Ask the patient and the family open-ended questions to gain more information about their assumption and expectation. We need to remain non-judgmental when giving information that reflect values that differ from that of yours. Follow the advice given by the patient about appropriate ways to facilitate communication within families and between families and other healthcare professionals. For instance, if you are dealing with a Pakistani patient with issues that are quite sensitive, that issue is about more or less the whole family issue. So the way you have to address it should be appropriate, so the person will be able to come up and start speaking. Other than that, you are not going to have anything from the person, because whatever the person says might jeopardize, have a repercussion on the family. So these are the issues that need to be looked at. Let's look at the 2.3. So we look at the culture, we look at the impact of society as a whole. Let's look at attitudes, right? Because we need to analyze attitudes to healthcare. What are people's attitude to healthcare? And here there are a few references for you to use, Joseph.
Okay.
Yeah. Terms of attitude is used widely. According to Solomon 2009, it states that an attitude refers to general evaluation of people, advertisement, object, or issue. And according to Brem et al. 2002, attitude is a mixed reaction, positive or negative, to a person, object, or idea. And attitude is lasting because it tends to endure over time. People's attitude is lasting. Right. So it's generally, it is general because it applies to more than the momentary event. Attitudes help to determine whom you choose to date, what music you listen. Two people can each have an attitude towards some object for very different reasons. The functional theory of attitude facilitates social behavior was developed by psychologist Daniel Katz. Unitarian in function, value expressive function, ego defensive function, and knowledge function. So if you click on psychologist Daniel Katz, you have a whole thing coming on that about attitude. Right. So the Unitarian attitude function, which describes the basic principles of beneficence and punishment. These are issues that you need to understand: people's ego and how they want to help and support people, people's knowledge function, and then normally an attitude will be dominated by a particular one function, but in some cases more than one function can be served. Solomon 2009. This is just an extract. Read further and you have more information about Unitarian function on attitude. That is a bit just going to give you some references if you read around that. Okay. There are many theories which explain and define the meaning and how to measure attitude. And the ABC model is one of the attitude theories which consists of three components: affect the person, affect, behavior, and cognition. That is the short form of the ABC. Firstly, affect is how an individual feels about regarding the object. Secondly, the behavior mentioned to the person's intention to take action. Thirdly, cognition is knowledge an individual's belief about the attitude object. All these components of an attitude seem to be important, but depending on a level of consumer motivation to relate to the attitude objects to define their relative importance, whether they are main or minor users, and so on. Another model is Fishburne model, which will just jump over that. Let's look at attitude and its relation to health and social care. This is very relevant. There's a growing realization that the UK is not a melting pot in which immigrants assimilate into the mainstream culture, but a country of many cultures, has led to a growing appreciation of different cultural groups. As a result, many healthcare professionals are concerned with providing culturally sensitive patient education. Remember, we are evaluating the cultural and social impact and attitude towards healthcare. Now, most professionals, health professionals, are concerned how best they can meet the needs of every single person that comes through the door because of different sensitivities in terms of people's culture. Right. However, it is a daunting task for nurses and other healthcare providers to become familiar with the cultural dynamics of all the various ethnocultural groups in the UK. No matter how experienced GP or nurse or consultant you are, it is very difficult to understand every person's culture within the UK. Therefore, providing services for different people for different culture is quite difficult. So when you are evaluating the cultural and social impact on attitudes towards healthcare in one national context, which is the UK, bring in all this aspect of it. So note this slide very carefully. Attitude and in relation to health and social care. It's a daunting task. No matter how trained you are, you might have Africans coming through. Even within Africa, there are so many people with different attitudes and different culture. And in the UK, even the Scottish and then the Welsh and then the Irish have different attitudes towards things. So it's impossible, rather, it is a virtually impossible task of learning about multiple cultures. And it is a more practical and how helpful for healthcare professionals or nurses to use a generic approach in doing cultural assessment. So they've got a generic approach which applies to everybody, but still you still have to be quite sensitive because sometimes the generic approach will not work. So through questioning, you should be able to identify the cultural needs of the person, and you'll be able to understand their attitude to the service that they are being given. So data obtained from a cultural assessment will help the patient and nurses to formulate a mutually accepted cultural and culturally responsive treatment plan for all. Right. Let's look at the next slide. So the basic premise of cultural assessment is that persons have the right to their cultural beliefs, values, and practice, and that these practices should be understood, respected, and considered when giving culturally competent care. For instance, if you are in the hospital environment and you are a health care personnel, you need to understand the attitude of Jewish people in terms of the food they take, and make sure that you understand their attitude towards food. Because if it's not something that Jewish people take, they won't. In the same way, the attitude of Muslims patients in the hospital is quite different in terms of the food they eat and even treatment they receive. So we should be able to evaluate the cultural and social impact and how it affects people's attitude in the healthcare. And I give you an example of Muslims in terms of their halal meals that they take, and then the Jewish food. I don't know whether they call it kisha or whatever it is. So they are all aspects of cultural issues that moves around their attitude towards the services that they receive. Attitude. And there are some midwives or doctors who will not be allowed to look after people from the Muslim community when they are coming to give birth. Because if you are a male nurse or a male consultant, their attitude towards you seeing their nakedness is different because of cultural difference impacting on their attitude. So we should be able to understand, respect, and consider when we are giving culturally competent care. The first step in cultural assessment is to learn about the meaning of illness of the patient in terms of the patient's unique culture. Right? What someone will see as an illness, maybe in a village in Zimbabwe, might not be an illness to somebody in England. It's all about attitude. Because probably if you are in Zimbabwe, if you look so thin, they might think that you are actually not fit. Maybe you are not feeding well, and if you are a woman, maybe your husband is not looking after you very well. Whereas somebody who is thin in England might be associated with what? Good or healthy eating. And somebody who is obese will be looked at as unhealthy. So these are all what? Attitude towards even the concept of illness and health, or depending on people's culture. Right. The table below shows questions to ask during cultural assessment to be able to know people's attitude. What do you think has caused your problem? Why do you think it started when it did? How severe is your illness? Will it have a long or short course? What kind of treatment do you think you should receive? What are the most important results you hope to get from this treatment? What are the chief problems your illness has caused you? What do you fear most about your illness? Now, going through these questions will help you to be able to understand people's attitudes to health. Right. By asking the patient and the family these questions, you can obtain valuable information needed for a teaching plan as to what needs to be done. It is important to remember that the patient's personal interpretation of the illness experience is more significant than the view of the disease. So the person's illness experience or attitude is more important than the disease. If the person's attitude or experience of illness is that as for this sickness is going to kill me, then you've not done anything at all. The person will die because the person has actually given up because of the attitude. So these are all issues that need to be understood. Healthcare providers should teach from a position of mutual understanding and collaboration rather than trying to impose traditional Western medical practices that are unlikely to be effective. So people's attitude are again impacted by their culture, and this needs to be understood so that we will not impose the Western medical practice, that is the traditional Western medical practice that are unlikely to be effective in a multicultural environment with different attitudes towards illness and health. The next step in the cultural assessment is to determine how embedded the patient is in his or her traditional culture. Some of them are deeply rooted in their culture. It will be difficult to change. Example is what happened in Pakistan. A lady with a lump in the breast that needs to be assessed by a male doctor. The husband refused, and there is no way that the clinician can take the lady for assessment and to be able to have a look at the breast. These are all issues that are embedded in tradition. So cultural embeddedness refers to how aligned the patient is with native culture. And the extent of the patient's cultural embeddedness has a major influence on healthcare teaching. Right. Again, we'll finish very soon, Joseph. Yes?
Sorry?
We'll finish very soon.
All right, it's okay.
Right. The table below also shows some characteristics of cultural embeddedness. What does the patient associate with? What type of neighborhood does the patient live in? Does the patient follow traditional dietary habits? Does the patient wear native dress? Does the patient leave his neighborhood to participate in larger culture? Does the patient use folk medicine or use the practices of a native healer? Does the patient come from an urban or rural areas in the native country? All these are actually features that are culturally embedded. What about patient satisfaction in healthcare services? We need to understand patient satisfaction and service quality in healthcare services, which is critical to underdeveloped service improvement strategies. Moreover, both Arden and Crowell comment that patient satisfaction is a service cognitive evaluation that is emotionally affected and is therefore a perception of individual subjectivity. And the patient satisfaction has come to be perceived as part of health quality of outcome that additionally encompasses the clinical results, health-related quality of life, and economic measures. Right. 2.4 says that evaluate the cultural and social impact and attitude towards healthcare in national context. That's the last bit that we finished. Evaluate cultural and social impact. Here we are asked to evaluate. Right. So again, we are using the NHS. In 2008, the NHS, in conjunction with major trade unions, the Healthcare Commission, and Academy of Medical Royal Colleges, carried out a major piece of research, including interviews with staff from 50 NHS trusts in a range of GP practices. Right, this is the reference, Ipsos Mori 2008. We are trying to evaluate the cultural and social impact. So this research was done. This research found that staff commitment, engagement, and productivity were strongly linked to 4 themes. The resources to deliver quality care, the support needed to do a good job, a well-powered job that offers the chance to develop, the opportunity to improve team working. These themes underpin the idea of culture of care barometer as it was first conceived by a group of leading nurses and healthcare managers. Going into a bit of theory here. As a measurement tool to assess the culture of care and different dimensions of that, and to see how this varies within an organization over time. As a tool to prompt reflection and on the underlying issues involved in creating a culture. For example, it was envisaged that the culture of care barometer could be used in one-tone or group discussion with staff to stimulate dialogue about the culture of an organization and prompt staff to think about what part they can play in creating a positive culture. And again, this is a theoretical aspect of evaluation of the cultural and social impact. That's the theory based. So that theory, the culture of barometer of care, is something that you have to read around with the references behind and see how best you will be able to evaluate the cultural and social impact. Right? And 2.4, if you're asked to evaluate the cultural and social impact, I've given you a bit of theory here, but then if you're doing the evaluation, how culture and social impact on people's attitude. In fact, you can, speaking from the African context, how do you think the culture and the society impact on people's attitude? This is a clear, we can have clear answers to this, because people's attitude is actually informed by the cultural background that they come from and the society in which they come from. That will determine the attitude towards healthcare in a national context. So if you use the UK for example, in terms of their culture and their society, if you look at their attitude towards healthcare, it's quite refined compared to developing countries. Their culture is that people are individuals on their own. It's not, people don't live in a community as we have. So your problem is your problem. So that culture and the society in which we live in, where everything is ready available for you in the healthcare system, means that people's attitude towards healthcare is enhanced by the culture in which they live in. If there is anything at all, people would like to go straight to their GP as a first point of call. And then if it means referral, the referral is made to the hospitals. What about the other cultures? Let me use a typical example of Ghana, where I come from. The culture is like that people are not on their own. Your father, your mother, your extended family, they are all there to support you in terms of illness. So the society as a whole play quite a key role. But attitude towards healthcare here is actually embedded in culture and society in terms of people telling you that the first point of call is to go and pray and see this is not ordinary disease. So go and pray or get some traditional medicine and try. So it will take a long time before issues are sent straight towards the hospitals. These are all culture and a society that changes our attitude towards healthcare. So here you can bring two arguments, one from a developing country perspective, that where the culture and the society is such that people don't see themselves as individuals because there are no support system there, that whatever illness or problem you are facing, the whole society comes in to support. Therefore, what advice they give you when they tell you, oh, try this, I think it's not an ordinary disease, go to this prayer camp, go and see this herbalist, or go and do that. Or at best, don't go anywhere. Just buy paracetamol and see if it will work. So people tend to go to the hospitals at quite an advanced stage. Now, if you look at the situation here, we can see that the NHS is there to support them. Again, people are individuals. They don't listen to what the society says, because the society hasn't got any impact on them. The government is everything. So if you have any health issue, the first point of call is to your GP. And then from the GP, that will either determine whether you'll be given treatment there or you receive a referral to secondary care to be able to address the issue of health that you are trying to deal with. So you could see that we'll be able to evaluate how culture and society impact on our attitudes towards healthcare. But there are some people who still believe that even HIV is a curse. So in such culture and society, how do you expect people to listen to advice on prevention of the infection, and then trying to use condoms and all those issues that will try to prevent people from getting HIV, and even those who are positive, how they are going to accept the retroviral treatment. These are all dealing with culture and the society, how the society sees it, and that impacts on our attitude towards the way we use health services, which is quite different from that of the UK. I think we will end here, and thank you so much for your time. Just try and see if you can tackle learning outcome 1.1 up to 2.4, and let's see if we can make any headways. Get it back to me, whatever you can put together, and then I can comment on that and then see how far we can go, so that as soon as we finish all the learning outcomes, we have finished our assignment, so that we don't delay any longer. Is that right?
All right, I'll try.
Okay. All right. Thank you so much for your time. Saturday, we will meet at 6 o'clock.
All right, okay. You'll be sending or putting the recordings again on Moodle?
Yeah, I'm going to send the link even to your email address so that you can go on the link and then play it even before you go on Moodle. Is that right?
All right, that's right.
So I'm going to email it straight away to you. And for the slide, it's already on Moodle.
All right, okay.
All right, thank you so much for your time.
All right, thank you.
All right, bye.
Thanks, bye-bye. Bye.